I'm palpitating here inside, and actually after the whirlwind of activity the last few months, we are finally here, and the report is actually released. I hope that all of you actually enjoy reading the report and the messages that we actually have, and hopefully it also helps us enhance the transfusion safety. I may not be able to do full justice to the report. It is more than 250-page report, but here we are. I would try to actually then go over the highlights of the report. Now, you may have already seen it online, but this is actually the color, and the whole team have actually put together all the ideas for this. It is actually the jigsaw. It is working together, coming together with all useful phrases as well. That is the summary. So just for all the audience, we will have the foldable summaries as well that will be circulated to all the hospitals, and there are some reports available to buy. But first, just following on from all our morning talk as well, and I do that, in every one of my speeches, is actually having that pause moment. This is also actually a special year. It is 25 years of hemovigilance in the UK. It is time for us to actually pause, reflect. What have we learned from our experiences? What can we use to actually inform our future? And I think, there is optimism throughout the presentation. You would also be actually seeing what are the good news that we actually have, what are the achievements that we have been able to actually do over the years, but also what more needs to be done. But also a big thank you to everybody in the transfusion community, because we come together, and during these COVID times, we have shown how we work collaboratively to actually help save and improve lives. And it is that collaboration, it is that working together, which is ultimately going to be actually useful. And I'm also ever so grateful for everybody in my team members you would have been actually seeing buzzing everywhere. Nothing is actually possible without actually the members contributing. Now, how many blood components? So transfusion is big business. And in the sense, how many components are issued? So, in the morning you heard Professor Cheng Hong mention, it is over 2.1 million components. Now, from last year to this year, there has not been any significant change. It is actually still that many number of components, and that includes both the red cells as well as the plasma components. Now, you can see I can start picking up in the speed. They do call me the Indian Express, but, please let me, raise your hand if I'm going too fast. Now, although the short report is heavily recipient-focused, now for the last several years, we have been including a chapter on the donor hemovigilance. And there is a summary chapter where we have key stakeholders from all the 4 UK blood services contributing, and there are key messages here. Now, at the outset, I would also like to say, those involved in donor medicine, you may all be in different phases of introducing the donor severity grading tool that Mary, led the group to actually validate. In UK, we have not yet implemented that. We are in the process so that the next 12 months we will be implementing. Here in the UK, we have what we'd call as severe donor adverse events. There are 10 different categories, anything that results in the donor death or donor hospitalization or any donor intervention. So this is actually the key highlights. So when we look at the blood donations in general, they are actually safe in the UK. And in total, as you can see, it is more than 1.8 million donations that have happened in 2021. So all the data pertains to that calendar year of 2021. And that includes the COVID-19 plasma. But there is a low rate of serious adverse events. And remember, it is only those 10 categories that we have actually agreed in the UK, and it is around 0.26 per 10,000 donations. And the two common things that actually often we see year on year is the donor arm pain events following venipuncture. This is a big size needle that actually goes to the donor arm. Despite best practice as well, you could actually land up with a donor nerve injury. And the other is with the faints in the donors. And as you can see, there were donors who actually sustained fractures as well, but these numbers are small, but they can actually still, the faint can be severe enough to actually result in a fracture or even in a road traffic collision. But there were no reports in an apheresis donation of any anaphylaxis or hemolysis. There was one suspected air embolism, but the donor was fine. It was more on a precautionary basis that it was actually raised, and there were no donor death. Why are we interested in this? Because if a donor has any adverse event, it would be having a negative impact on the donor retention as well. And we see that 9 out of 10 donors, both for the donor safety as well, that we would be actually withdrawing, that you have 9 out of 10 donors were withdrawn, whoever had the serious adverse events of donation. And the important thing is, similar to the patients, even for donors, why do we need to actually know all of this? A, to improve the donor safety, to make our systems better, but also to actually then be able to say, these risks, how do we evolve? How do we inform the donors as well about these risks? And it has to be, it is imperative that everybody who works in the donor medicine should be actually working towards improving the donor safety. There are several trials that are also going on to actually see how can we improve the vasovagal events as well in these donors. And it's also important to recognize, like with our transfusion reactions, despite the best practice, you could still have, some of the donor complications occurring. Now, every year we also produce a summary infographic that actually just is a visual summary, and that is available in the report as well. Now, for the main bulk of the report, this is on the transfusion recipients, near misses, errors, and reactions. Now, one of the good news, we have always had great participation in the UK. But every year we would have one or two hospitals who may not be actually submitting a report due to various reasons. This is the first year where we have had one report was submitted by every NHS trust or health board across the UK. And that is actually something to celebrate, that we are actually having that reporting culture here and learning and sharing the lessons learned. And the second thing that is also important is we are aware that there are categories where there is a bit of underreporting. So there should be no room for complacency. We need to actually also look at how we can actually improving in the different categories. And when we looked at the reporting across the months, because the pandemic is by far not over. We are actually already talking about another wave as well, but we're managing to live with it. Hemovigilance, fortunately, was not affected. The reporting was not affected, and last year, in 2020 report also, we showed the same. The number of the reports that we receive is roughly the same amount, around 4,000 and odd, and that's the same that we actually received. And over the months as well, you can actually see, it continued through the months. And for those who are not familiar with the different categories, now we collect on the transfusion reactions. These are the pathological reactions that you would see, like the febrile reactions, pulmonary reactions. We collect on the adverse events and the errors, as well as on the near misses, which is a more proactive form of the reporting. But equally, more recently, what we have also started is actually, on that safety to approach that we actually heard as well. It is getting that holistic view on the safety. We're still very early in the journey, but this is actually beginning learning from excellence. This is the short ACE, which is acknowledging continuing excellence in transfusion. And a few key highlights to actually then say, this is the summary data. I'm not expecting you to read the whole thing and understand all the codes, but essentially, broad categories are included. But this is similar to the preceding years. The near misses that we actually see always constitute more than 1/3 of our reports that are submitted to SHOT. And which is, again, a good thing. So we have a slide about near misses. And all those stars are the pathological reactions. So we still also get the pathological reactions as well actually happening. Now, this slide tells us about the cumulative data, so being in the 25 years of hemovigilance, how much of the data that we have. So you can see, we broadly have divided it into the 3 different groups. The top group is actually something that you may not be able to prevent, even with the improved components. There could still be, like, for example, TTI, even with the best available ones, it could still be in the window period, or the test may not be actually sensitive enough to pick up. The next group is actually things that you could influence, but you could not completely prevent either. But the third one, the bottom group, where you're actually seeing the maximum number, is where things are happening due to preventable errors. And these errors are largely the systemic errors which we have not been able to actually address. And that is where we are trying to actually improve, and that is where we are trying to focus and make an impact in that particular group. The other key highlights that we often actually also want to know is about the transfusion-related deaths. Now, last year when we presented, it was a grim news that the number of deaths had suddenly gone up with especially the delayed transfusions. Now, the number has stayed, it is slightly better from 39 deaths the preceding year, it is 35, but we still need to actually improve on that. As you can again see, the top the 2 causes of the deaths are the TACO, the transfusion-associated circulatory overload, as well as the delays in transfusion. And when we look at it in the last 10 years, so if we look at that serial trending data, you can see of all the 247 deaths, again, the top 2 causes of transfusion-related mortality in the UK are TACO and delays. So you can see the color code, and those are the 2 bars that I have actually seen for the last 2 years. Now, the number of deaths from delays is actually reduced this year as compared to the last year, but nevertheless, that's a number that we need to actually reduce. So, from the deaths now, let's go on to the other news that we have of the highlights, is in 2021, there were no ABO incompatible red cells in the UK, reported in the UK. Another good news. So as you can see this graph, this is again since the reporting began in 1996. You can see that downward trend in the overall downward trend, although there may be some spikes in the middle with the ABO-incompatible red cell transfusions. But we do continue getting ABO-incompatible plasma transfusions. So last year we had 3. Now, I'm not able to go into every one of the case details, so all these would be available in the report for you to see. But again, the message is, a few years ago, one of our key recommendations was staff needing to be aware of ABO compatibilities with both the red cells and the plasma components. And all of these was actually where the incorrect group was actually given, the group O, given to the non-group O. And then when we see what was the outcome of the ABO-incompatible red cell transfusions in the 25 years, now you can see all the various interventions that have happened through the year. So the BSQR was that blood safety quality regulation, which actually started mandating in the field of transfusion, the training, the competency made it more regulated. And that also the need for the competency assessments came through. So if you see up to 2005, 15 deaths were reported, and since then you can actually see there are improvements, and we see 5 deaths following the ABO-incompatible. But even 1 death is actually too many. So we are actually still needing to actually look at different ways how we can actually address this. But an important, all of you would be actually seeing this year on year, this iceberg phenomenon, that although the numbers are actually reducing, it is actually what we need to actually address is below that level. So, for every one of them, you can see how many wrong blood in tube incidents actually keep happening. And they're all, the near misses or the good catches that we would see. We need to actually look at how we can actually prevent those from happening. Is that somebody's bleep? Okay. I was suddenly taking me back the years as to where is my bleep now? So what are the common themes that we actually see in all of these? Now, the first is issues with the LIMS, the laboratory incident management systems, and the alerts, overriding the alerts, or they're not properly designed. Also, lack of adequate training and understanding in the staff. And it may also be the way the training was actually delivered, not able to actually understand, or it is a hurried training as well. So it is how and what has also been actually then done. And also there is a lot of human factors. It's cognitive bias, like the assumption bias, and also incomplete checks, and lots of human factors like the distractions, workload, as well as staffing issues that are actually contributing to this. And we also actually have seen reports where, they know that they shouldn't be checking 2 units, but because of the workload, you're actually then getting multiple units on the ward, and they are actually getting distracted with this. And we have seen incidents relating to this as well. And so, we know the 10 steps in the transfusion pathway as to how, errors can be introduced at any step. And also, we also know that there are several incidents where, each one is making an assumption that there is no error in the preceding step without actually the appropriate checks. So the aim is to actually get it right first time, also not to make any assumptions about it. So that was the ABO incompatible transfusions, but alongside the incorrect blood components transfused, we also have where specific requirements are not met. So this would be where somebody needing an irradiation, irradiated blood components has not received that, or the appropriately phenotyped blood has not been actually given. Now this, by far, is one of our biggest contributor to the incorrect blood transfusion. So apologies for a lot of abbreviations. Now those from outside UK may not be familiar with that. So IBCT is the incorrect blood component transfused. So as you can see, it is actually, more than 2/3 of the reports are due to specific requirements not being met. And the errors, and we are not in any way a blame culture. So we are not saying where it is, but also trying to understand, what are the pinch points, what are actually the weaknesses, and what are our blind spots that we need to actually address. And we see that it is happening both with clinical errors as well as the laboratory errors. And where does it happen? It is right at the initial step where somebody is making the transfusion decision and requesting the blood. Now, if the clinician is actually not picking that need for the specific requirement, and the transfusion laboratory is not aware of any, and this is the first time they are actually getting the patient, they are completely reliant on the clinician sending that information. So it is that completeness of that information. It is that natural question that has to actually come every time a request for the blood component is being done. It is not just what component, how much do we need, when do we need it, but also is there any specific requirement that we need. And often we see the same things, the communication errors, the gaps in the knowledge and documentation. So you can see the common themes that are actually coming through in all the errors that we actually see. Now, we did issue a safety notice. This is not an alert, but a safety notice that we issued earlier this year, because the specific requirements not met are by far, nearly around 8.5% to 10% of our reports. But last year, we started seeing a reduction in this, and this is the safety notice, again, available on our website. This is actually, again, coming at it from a process pathway, from a systems thinking pathway. Can you actually look at the whole journey of the patient and the journey of the blood and see what are all the different steps, at different steps of the transfusion pathway, what are the different interventions that you need to be actually putting in place to ensure safety? Moving on to some of the other categories. The other one is avoidable, delayed, and under and over transfusions. Now, last year, we had a spike, as I mentioned, in the number of the delayed transfusion. This is both in major hemorrhage scenarios as well as non-major hemorrhage scenarios. And you can see the number of the cases that were reported, again, continues to rise. But the number of the deaths were actually reduced, so that is from 12 in 2020 to 9 in 2021. So there is still, again, work to be done. But all of you in the UK would also be familiar with this CAS alert. So everybody has been kept busy in the last 6 months. And this is actually, again, system-level recommendations about what needs to be put in place to actually address these preventable delays. Whatever be the reason or the indication for the transfusion, whether it is major hemorrhage or anemia due to hemolysis or due to any other reason that you're having a severe anemia. So hopefully, I think the information over the next few years would be actually telling us whether the recommendations were effective, implementation was effective, and whether there has been a downward trend. And again, bottom line, we have that illustration is mainly to indicate in all of these, the commonality is the poor communication. So again, in all those situations where the delays have happened, is either due to assumptions, or is it actually, yes, in a small percentage of the cases, the clinician may not have recognized that there is a major hemorrhage. That is especially so if somebody has, covert bleeding, such as a gastrointestinal bleeding. But we still actually see that communication between the clinical and laboratory, between shared teams, or when a patient is actually being moved from one unit to the other unit, those are all the places where incremental delays come. The other bit of it, common things, I think we will also get that in the panel discussion as well, is how fragile our blood supply is. And therefore, it is very much important for us to actually focus on, are we making the right transfusion decisions? As we have often actually heard that the safest transfusion is the one that is not given. And equally, the transfusion should be given where it is needed, but you're making the right decision. Are you balancing all the risks and the benefits? We often see that every year we get a small number of the patients where hematinic deficiencies, so it is iron, B12, folate deficiency patients, getting inappropriately transfused. And as we all know, anemia is actually developing over time, in the hematinic deficiency, and you would have a state where they would be deficient without an anemia before it actually results in a severe anemia requiring transfusion. But along this journey, there should have been several opportunities where they could have picked it up without the need to actually come to a severe state. And even if somebody who is actually having severe anemia, the amount of blood component needing to be given is only to tip them over to actually a state of safety. So if somebody is bleeding, if somebody has cardiovascular compromise, then only that amount of the blood component to be actually given to take them to safety. So we often see that there are avoidable transfusions. The other big thing is about our O negative supply. So it's only 7 or 8% of our population which is actually O negative, but the demand in the hospitals is nearly double. So again, we see how many O negatives are being used inappropriately. When we make that decision of inappropriate use is actually where already there was cross-match blood available, but it was actually not sought. Or they could have actually asked for group-specific blood, but that was actually not sought of, and they have just used the O negative. So I think it is that anybody in the front line in that situation should be constantly thinking, how do I rationalize the use? Is there actually more specific blood component that can be actually given? And also, there are, the uptake of the O positive in the different groups, although we have national guidance, is varied across the country. But we also actually see, in those, where you could use the O positive, how many cases we had. And again, that number is there, nearly 13 patients where we had. So it's all about, it is not just the reactions, but also how are we using and making those transfusion decisions safely and reducing actually the risk. And over the last couple of years, we have, I'm not going to go through this in detail, but we have this A to E decision tool, which is actually just helping people to prompt to actually think about what are the different things that you're taking into account when you're making that decision to actually transfuse. Equally, we are having various apps that are available from the patient blood management, such as the Blood Assist app and the Blood Component app, which is actually then helping the clinicians make that decision as well and weigh the risks as well as the balances. Now, moving this in slightly, so the other errors that we also collect are the anti-D immunoglobulin errors, and you may be familiar with all that, the RA-ADP program, as well as following a potential sensitizing event as well. The total number of incidents, roughly the same, so slightly lower, was 341 incidents. And often, again, the pattern is actually similar to the previous years. So we see late administration or omission of the anti-D accounted for most of the reports, and again, 2/3 of the reports were due to that. Again, you can see the factors that are actually coming through. So when we are collecting that information, and one important thing to note is SHOT is not directly involved in any of the incident investigation. But what we do is actually then ask our reporters to submit, as part of the local incident investigation, what were the factors that have been actually identified, and this is actually what has come through from the reports. So you can see there are gaps in the knowledge, lack of understanding, again, communication errors, so you can see the same themes that are actually recurring, and these need to be addressed. And also the other thing that we have seen is early discharges, for the benefit of the patient, has an unintended consequence that they have actually forgotten or missed that dose to be actually given, and that then results, in that anti-D missing out completely. We've also seen for the last few years cell-free fetal DNA errors also, and that is actually being trending. We are trending that and seeing the patterns, and this is both the false positive as well as the false negative results needing to be reported to us. And as with anything else, what we are saying is, again, look at the system factors. So you need to have a robust system. You need to actually have that refrigerator monitoring, traceability, because this is a blood product, and you need that as well for the anti-D. And these are the key recommendations for the anti-D errors. Again, I want you to pick on the main themes is about that use of IT to improve safety. Use of IT and that interoperability is actually the key thing that we are seeing here. Again, that's a recurring theme that we actually see through the report as well. Now, alongside, we also actually then collect reports of immune anti-D. So these are the cases where there is the sensitization that has actually occurred. And one of the themes are similar to the preceding years. So, you see there are cases where, despite the best practice, they have resulted in immunization or in the mother and potential risk to the baby as well. And the common things that have been actually noticed is obesity and delivery beyond 40 weeks. They remain as the risk factors for sensitization, even when they are ideally managed. And again, these are similar to what we see in the guidelines. So following fetal-maternal hemorrhage, every effort must be actually made to clear all those cells. And auditing that and learning and changing your practices. And these cases should all be reported to SHOT as well to ensure the learning. So again, the theme, even in this immune anti-D, is interoperability of the systems and the IT systems, which is actually a gap that has been actually identified, which is threatening the patient safety. And laboratory errors now, they are also actually figuring up to 8 to 9% of the reports that we actually receive are related to the errors in the laboratory. And you can see in these 10 steps where we commonly note is the component labeling, followed by the testing as well as the component selection. These are all the steps where we see errors being introduced. And this has both for the transfused errors as well as the near misses. So there are these, the key SHOT messages that are actually there in the laboratory chapter. And again, nothing different, but what we are also saying is that pause before the blood component goes out to actually make sure that it meets the specification that has been actually requested. And also often we see the human factors perspective. There is that alert fatigue, the cognitive bias that will be coming in. And therefore those alerts should be actually, they should be actionable. They should, what are the measures that you can actually take to avoid that alert fatigue as well? Again, coming back to that communication and whatever information that comes from the clinical side, are we updating that in a timely manner onto the limbs? And what can you do to also prevent the delays? So I think, although I'm skimming through the highlights of these, there is quite a lot of the information in each of the chapters, so I would really encourage you. And also there are learning cases that have been actually included in them, so you can relate to, what could be happening in each of the situations. So this is the pause, aid memoir in that sense that has been, devised. So please do look at it, and it would be in the summary as well. So, what is that? Ultimately, what helps you to actually make sure that the component that is leaving the blood transfusion laboratory is the right one. So often what we actually, you're seeing that theme of the IT-related errors, and, the total number of reports consistently remain the similar numbers. So we had around 374 IT errors reported in 2021. Again, same theme, that interoperability. So IT is more a combined chapter where you're actually looking at where IT contributed or could have prevented, the errors in all the different categories. And what we are really excited about is actually the work from the script group. And I have a slide about the script coming up in a minute, but this is actually, again, working together to improve the safety and to enhance the safety. So, I'll tell you more about it in detail. And the two recommendations from the IT chapter are, again, emphasizing that collaborative working. The different organizations need to work together, and IT to be used to its full potential. So there is definitely, and for several years, implementing that IT vein-to-vein has been a recommendation from SHOT, but repeated surveys have also shown how there are gaps, and the barriers that are there are largely, either people not understanding that it's a priority, or there are clashing priorities. There is no adequate allocation of the budget as well there. So I think there really needs to be, a push for how do we introduce this IT to help improve safety. Now, a bit about this script group. So this is all about, getting everybody involved in IT in transfusion together. So SCRIP stands for SHOT UK, Collaborative Reviewing and Reforming IT Processes in Transfusion. It was actually formed a couple of years ago, and it was started by the laboratory as well as the IT working expert group members in SHOT, and we've reached out to different organizations and getting all the stakeholders. And what we really wanted to understand is, what is the current state? What is actually the gaps that we identify? How can we actually engage with even the providers and the suppliers of our IT, for transfusion? And what do we need to do? And it is not just for getting the IT, but also having access to subject matter experts. How do we train our staff? How do we provide adequate resources for our staff as well? So what we really did was an initial survey of all the hospitals, and it was great. We had around 85%, and thanks to everybody who participated in that as well. It helped us identify the gaps across UK. And we also then did a one-to-one call with all the LIMS suppliers that were actually identified in that survey. Now, I'm not going to go into the results of all that surveys, but you can find that on the webpage, and if you just scan that QR code. But it helped us identify the gaps, identify the barriers as well, and bring all the stakeholders together. So we've already started actually the discussions with the Health Education England to actually help develop a learning module. We've also actually then started the initial discussion with other key stakeholders as well. And we have like the National Blood Transfusion Committee, we have representatives from all the other devolved nations as well. And it is truly, working together and addressing the gaps immediately. And we're also in the process of developing toolkits, also the different FAQs. So somebody is going through an introduction of a new LIMS, you would have somewhere that you can actually find those questions, and also kind of a phone a friend as well. So, you would be having, again, that is our aim, that we can actually then develop that community to actually help. And this is just building that impetus for spreading and implementing that IT vein-to-vein in the UK and leading the way. So this was kind of a whirlwind tour about all the errors, but I think you've seen this slide and you've heard it as well. But a big thanks to Paula as well as Alison here, who introduced this human factors investigation tool in 2016. And you've all seen the investigation tool even in Professor Cheng Hock's talk as well. And as I said again before, SHOT is not involved in the incident investigation, but we actually collect that so that we are looking at those incidents from a human factors perspective. And what the story that it told us was actually helping us inform our actions and our recommendations. So when you look at it, what we started asking initially was just broad categories as to, what were, as part of your investigation, what did you think was the causal and the contributory factor? And what have been the interventions that have been actually put through? What we have now done is actually an evidence-based incident investigation framework, which is the Yorkshire Contributory Framework, was then used and adapted to develop this, expand this, so that we are looking at it, from systematically from all different perspectives. So, what that has actually told us is over the initial 5 years, it is still, people have a lower threshold, all the teams have a lower threshold to actually blame the individual. Because often I think our question is actually, okay, who was the one who did that deviation or who made that error? But what we are not asking is actually the right questions. But what we have shown is with that improved awareness and knowledge and training and even awareness of the human factors, there is a slight reduction, but there is more work that we need to actually do. And why are we talking about human factors? Now, is it just because we have introduced it? No, there is actually evidence here to actually show that there is a reduction in the errors when you're looking at things and building systems from using human factors principles. There is reduction in waste. There is increase in the staff engagement. There is also staff well-being and everybody working well together. You have better experiences for everybody involved in that journey. So whether it is patient, donors, or staff experiences, as well as improving safety. And human factors, when we are talking about not just an incident investigation, it is about even building the system. Now, one important thing that I would like to actually stress, and this is something that we have elaborated on in the human factors chapter as well, is when we say apply the human factors principle as a conclusion of your incident investigation, saying it's a human error is wrong. Because what we are really prompting is by applying these human factors principles, you're really trying to identify what are the gaps in the systems and therefore what are the system level factors. That does not take away the accountability. So you do have a very, very, very small minority where there is a deliberate action. Now that is actually addressed differently. Here you're saying is through the gaps in your processes, through the gaps in your systems, that there have been errors that have occurred. And it's also important that we mind that our words make worlds. So even the languages that we actually use. So we need to understand that what we are, in the healthcare system is actually a complex system. And human error just points to one individual in a complex system, and you're really not taking into account everything else that is there in the system. But we need to understand how the systems work and address those deficiencies. And in the words of Stephen Shorrock, now he's the one who actually then spoke about work as done, work as imagined, all the differences that we have actually then, spoken about. So some of you may be aware. So, those are his quote there. What is relevant is the difference between the normal variability in the human performance and what we define as recklessness. And human error is none of those. So therefore, you should avoid using the human error as a terminology in that. Now, I just briefly mentioned about human factors. Now, in here, we have used it in the context of you investigating incidents through the human factors lens, so applying a human factors-based framework. But we're also saying that human factors, it has to be the principle that drives even your building of your systems. So you're, making changes in your laboratory or even in your ward. Think of it from a systems thinking point of view. Is it user-centric? Is it actually, are you complicating and making it more difficult for people to do the right thing? Also about your SOPs and the instructions. Just in the morning, we saw about if you have 200 steps, then, in your process document, then, people are going to have workarounds. So, simplify. That should be actually the mantra that we need to actually use. Equally, we are also building those documents using the people who are doing those activities as well. So, they should be involved in writing those documents as well. And training the people. So now, again, several, for the last few years, we have been saying about the importance of holistic training. It is not just the technical training about what needs to be done, how it needs to be done, but also why it should be done, as well as combining it with the understanding of human factors principles. Now, in the UK, we have a national patient safety syllabus that actually then mandates that all staff, irrespective of the background, whether you're working in the clinical or the laboratory area, should have a basic understanding of human factors principles. And that actually has created a big impetus, in everybody trying to actually then learn and then be aware of it and apply in various aspects of your clinical and laboratory life. And of course, we have spoken about investigating when things go wrong. So that is about, just the reflection on the errors that were reported, in 2021. Now going on to some of the reactions that we actually see, some of the key highlights of the different pathological reactions that we have actually noted. This is about the febrile allergic hypotensive reactions. Now, last year we had seen a jump in, from the preceding year of around 10%. So the number this year, in 2021 is the similar numbers. There were no deaths, but there were 74 cases with major morbidities. But the themes continue to remain similar. So febrile reactions are most commonly reported. So this is more than half of them are febrile reactions. And a quarter of them, 23% are actually then categorized as severe. And we continue seeing issues with categorization of the different reactions. And I'll come to that in a minute, how we have tried to actually then help out with that. And the pattern of the reactions are also, pretty standard. So you have red cells usually associated with febrile reactions, and plasma and platelets causing the allergic reactions. And what we often see, it is not just the problems in categorization, it is actually if somebody is reacting, you throw everything in. And you're therefore using a lot of inappropriate medications as well. So and that continues. And we see that in one of the reports, both in shifting from one category to the other category, as well as rationalizing why that medication was actually needed based on the symptoms the patient had. And that is just a visual summary about the type of the reaction based on the component. And again, repeatedly in the reports, we have shown that when you look at the reactions as a percentage of the platelet units issued, apheresis platelets, more commonly you're actually seeing the allergic reactions, as well as the pooled platelets, it is not as much, but you're seeing a higher number of the febrile reactions. And two related topics in the febrile allergic reactions are the reactions that we, trend in the IgA deficient patients. So, you know that IgA deficient not all IgA deficient patients will have transfusion reactions, even when they have anti-IgA antibodies. So we were trying to actually see how many of these turn out to be IgA deficient. So 4 reactions reported in patients who on subsequent investigation were discovered to have severe IgA deficiency. And the pattern was all these reactions occurred within the first 15 minutes. And actually the important thing is the importance of that monitoring patients, especially in that initial bit, is actually really driven from these reports that we actually see. And there is different patterns of the reactions that were seen in these patients. Anaphylactic reactions coming from a different angle. So all of you are aware about what anaphylactic reactions are. There were 32 of them that were reported. And in 15 of those cases, the transfusion was actually routine, and 5 of them actually was happening in an outpatient or a daycare center. So again, no complacency when you're having an ambulatory transfusion. The monitoring has to be actually rigorous enough. And in this, children were disproportionately represented. There were 10 out of 32 cases. Nearly 1/3 of them were in children less than 18 years. And again here, there was one case where there was an unnecessary transfusion. So there was a 4th unit of platelets that were given to a patient with intracranial hemorrhage who had taken aspirin, and one patient was subsequently discovered to have an IgA deficiency. So again, coming back to the point that this reaction could have been prevented because the transfusion was actually unnecessary. So from the very beginning, from your very first step, are you making the right decision? Is the transfusion really necessary? Are there any alternatives? And then proceeding. And once you're transfusing as well, using the safety checks as well as monitoring the patient is really vital. So the group have actually, the working expert group have, there is a short bite as well. And Kat Booth is here from the working expert group as well. And we have this algorithm that is actually helping differentiate the different categories of the febrile allergic and hypertensive reaction, as well as their management. Now, by no means, it is very easy retrospectively without an active patient having a reaction in front of you. It can sometimes be difficult, we acknowledge that, but there are some pointers that can be actually used, and this algorithm is there both in the report as well as in the short bite as well, so please do use that for your practices. The next category is about the hemolytic transfusion reactions. So there were 44 hemolytic transfusion reactions, of which we have, the distribution, similar distribution that we have every year, is about a smaller number of the acute hemolytic transfusion reactions, a bigger delayed hemolytic transfusion reaction. Unfortunately, there was one death that was reported in a patient with sickle cell disease. Although there were other factors, they did say that it was related also to the reaction. And among the antibodies, no surprise there, anti-JKA antibody remains the most frequently implicated in hemolytic transfusion reaction. Now, Often it is always due to the red cells that you actually see. Now, after several years, I think the last one was in 2016. This year we had, in 2021, we had one acute hemolytic transfusion reaction, and this was following non-ABO identical platelets to a patient. So again, clinicians need to be aware of those risks as well in the patient. And all individuals involved in the transfusion process, therefore, again, coming back to sharing of that information and communication. So when a patient comes, the history of antibodies, history of transfusion reaction, that makes it all the more important, and especially multi-transfused patient. And that information, what are we doing with that information, and what and so what? So are we telling that in laboratory, sharing it with all the teams who need to know to actually help them make safer decisions? So, at the very outset, when you're meeting the patients and the carers, that should be part of your care pathway, that you're asking them about previous transfusion reactions as well as any other antibodies. And the access to, system, the SPICE. So this is actually with the database, whether you have access, whether staff are actually aware about how to access this as well. And there is a lot of work going on to improve the accessibility of the red cell antibodies, and especially when patients move from hospital to hospital as well, or in a shared care. Now, one important thing, an important message in the recent years has been about hyperhemolysis. So this is the hemolysis where it is not just the donor cells as well as the recipient cells are also actually going to be hemolyzed. So there were 7 cases. We do know that these are underreported. There are a lot more investigated in the red cell immunology labs. So there were 7 cases reported to SHOT in 2021. And 5 of these were in patients with sickle cell. So more often it is actually in patients with sickle cell disease. Now, the important message is hyperhemolysis can be actually seen even in non-sickle populations. So again, there should be no complacency that this is not a hemoglobinopathy patient. So I have the next slide which summarizes them. But in their management, and this is actually a therapeutic nightmare, it's also a management nightmare when you have a patient with hyperhemolysis. And this is one where you need to actually, it is an emergency, the management needs to be actually done after liaising with also the other transfusion consultants, and you need to be able to take those prompt decisions. And monitoring the patient's reticulocyte and ferritin levels can be helpful in managing this and differentiating it from the other hemolytic transfusion reactions. And treatment protocols, you have variations of the immunoglobulins, intravenous immunoglobulins, steroids, as well as erythropoietin are used. So this is the message about the hyperhemolysis. So as you can see from 2017 to 2021, there were 30 cases of hyperhemolysis that were reported. As I said, this is underreported, but this at least gives us a flavor of the types of cases. Sickle cell contributed to 25 of them, but there were 5 cases. You can see there was post-transplant patients, 2 of them, Diamond-Blackfan anemia, MDS, myelodysplastic syndrome, and Rosai-Dorfman. Rosai-Dorfman is sinus histiocytosis with giant lymph nodes that you get. So there may be some immune dysregulation, but you're seeing, that hyperhemolysis can occur, and it can be acute, it can be delayed. And therefore, again, monitoring of the patients, the informing the patients, and the patients being aware. So when you're giving them as ambulatory transfusion, in the discharge card, in the post-transfusion information, do the patients know what are the red flags? When do they need to seek medical help? What are the changes that they need to know? And it is again back to communication, better informed patients, better informed staff. So yesterday we have heard from Tom about the pulmonary complications. So you would have grasped, and for those who were not there, now all of you are familiar with, we have seen how TACO is actually one of the leading causes of deaths year on year. So they contribute significantly to morbidity as well as mortality. And TACO by far is actually the highest number. Every year it was growing in numbers. Last year was the highest number in 2020. Now this year it is 131 cases of TACO. And you're all familiar with the TACO risk assessment. Now it just helps you identify what are the vulnerable groups of the patient. Now, although, we think that it's all due to fluid overload, the pathogenesis is slightly more complex. There could be an element of inflammation as well involved in this. But having that risk assessment is able to identify the vulnerable patients, and therefore appropriate mitigating measures can then be introduced. And last year, we also actually brought out this TACO incident investigation tool. Now, it is just to actually help identify what were, again, the gaps and what could be done better to actually then help mitigate these risks in these patients. And challenges, now what we have is really categorization of the pulmonary complications. Now, TACO, you have validated criteria, as we heard from both Joe and Tom yesterday. You have good validated criteria. You're able to clearly put them in that box of the TACO. But even those cases which have the flavor of a fluid overload must be TACO, but not fulfilling all the criteria, they then come to the other, it is that waste paper basket image that Tom showed. So it is that complexity of the categorization. And, last year, there was this conceptual framework, with the relationship with all the different categories that were actually introduced. And that debate, those discussions still continue. So, what does it mean from different perspectives? So whether it is from a clinician perspective, from a donor or a patient perspective, or from a hemovigilance perspective, what do we mean by each of these different complications? And therefore, the biggest debate that we actually have is now, do we need to lump all the pulmonary complications together, or do we need to split them still? Is there any benefit from splitting them? And it is just to give a flavor of the complexity of the categorization, and it is not just in the clinical staff, even at the hemovigilance end, even with pulmonary experts sitting in, we would still be actually then debating about, does this fit into this versus this? Many a time it could be due to the paucity of information, because it's real life. You may not have access to all the investigations. The patient is deteriorating quickly. You're reporting it as a suspected case, but when you're making that assessment at our end, you don't have all that information. So there could be paucity of information, or it could be multiple factors, and these are really sick patients with many things going on, and therefore you are not able to differentiate what exactly is the cause of this. So more work is actually being done. It is not just within the UK. This is actually a debate worldwide, and there's a group being actually led by Joe and Alexander Vla and his team. So we are looking into getting a harmonized reporting form, as well as actually trying to see what is really important and what do we need to actually collect as well. Moving on to transfusion-transmitted infections. So a couple of brief messages about what are the key things that we need to know. Any suspicion of a transfusion-transmitted infection should be reported to the respective blood service as soon as possible, because that needs to be thoroughly investigated, and there are several actions, tracing it back to the donor and the other donations and impact as well. It's also important that everybody who works in transfusion should be aware that there would be an archived sample that is stored for at least 3 years, and testing can be actually performed on these samples if a TTI is suspected. So therefore, the earlier that you actually do, they can be actually then use that time frame to actually test that sample as well. And all look-back investigation should be reported by the UK Blood Services. Now, look-back is actually from the donor's end, so that is different from investigating a TTI. And that is actually collated as well. And it is important that when somebody is consenting a patient for blood transfusion, they need to have up-to-date knowledge about what is the screening methods in place, how do we ensure the donor and donation safety, what is the small potential of the TTI, so it's not zero. While it is actually safe, it is actually low, it is not zero, and that needs to be actually then conveyed as well. And it's also a legal requirement that all transfusion-transmitted infections must be reported to to MHRA. And that includes all the confirmed TTI. Now, another good news that we actually have in this is there were no TTI that were reported in 2021. So although there were several investigations, as you can see from the numbers, both from the bacterial infections as well as the viral infections, but there were no bacterial or viral TTIs that were reported in 2021. There were also no parasitic infections for investigation in 2021, nor were there any variant CJD investigations as well in 2021. And the residual risk continues to be very low. So the risk of a potentially infectious HBV, HCV, or a HIV donation not being detected because it is in the window period is very low, at less than 1 per million donations tested. So everything is being done to improve safety. Alongside, you also heard yesterday Katie, who actually then gave a brilliant lecture on the fair and gave us all an update. So this is actually just very briefly, what were the other changes? So from not just also safety, but also an inclusive approach to donation as well as transfusion. So from summer 2021, the FAIR, which is actually standing for the assessment of individualized risk, the blood donation policy was implemented across all the UK blood services. So what then, what is the main change that happened is the same questions are actually then asked. So it is gender neutral donor safety check. So it is actually from being a donor health check, it is actually more about a donor safety check. It is about the safety of the transfusions that the focus is. And the routine surveillance was adapted so that we are monitoring, are there any positive donors? What is actually the review of those who recently acquired as well? And also, a very close monitoring on the impact of this fair has also been done. To date, there is no evidence that it has impacted on any recent viral infections, and no TTIs have been reported. Now, syphilis does continue at a higher rate, but that was already there even before the implementation of, and that is just reflecting the high levels in the general population. And the other change that also happened was recommendation to withdraw the questions relating to partners who have had sex in the parts of the world where HIV is endemic. That was also approved. So these were some of the key changes, but this, as I said, is only the highlights, and there are more details. And if you go to the NHSBT website as well, you get the whole report from the FAIR study. And what has taken up our lives in the last couple of years is the COVID-19, and then we all ask about, yes, we have, the number of times that we have changed the donor selection guidelines and the policies and the deferral duration. So, the question always would be, is that a risk? Is there a risk of transmission through the blood transfusion? Now, while there is a theoretical risk, there has been no case of COVID-19 transmitted through the blood transfusions. Now, at NHSBT, there was also actually retrospectively, so the samples were being kept of any donor who had actually then said that they were positive. When they reported post-donation, the sample was actually then kept and retrospectively tested. While in a small number of the donations, they did see the SARS-CoV-2 RNA, one of these units was transfused and hence did not pose a risk to the patient, but there were no known cases of the transfusion-transmitted coronavirus infections. But again, no time for complacency. While more data is coming in and there is assurance, the virus is also actually something that is actually developing. It's not the same virus that we started off with, and therefore the same level of surveillance, the same level of precautions should be actually then continued. Now, the last few, I'm just conscious I have 10 minutes, and then, so the last 3-4 is more summary of the various, so depending on the different patient sets, we have summary data that we actually include in the chapters. One is about reports relating to the hemoglobin disorders. This includes the sickle as well as the thalassemia patients, and year on year we collate all the reports, and that is from all the different categories, whether it is febrile, hemolytic transfusion reaction, etc., and errors as well. So there were 2 deaths reported, unfortunately. One was in a patient with thalassemia intermedia, and this was due to acute hemolytic transfusion reaction, and another one was in a sickle cell disease where there was a transfusion delay as well. And there were 10 cases associated with major morbidity. And all of us are familiar with the management of these multi-transfused patients, that alloimmunization is a risk, and therefore prevention is actually better than managing a patient with multiple red cell antibodies. So therefore, that each transfusion decision, again, that you're actually making must take into account, again, the benefit as well as the risk. And it should have a clear guidance, not just actually necessarily topping up for the sake of topping up and normalizing the hemoglobin. And robust processes must be in place to ensure that, again, that communication to the laboratory. So, is the clinical staff who are requesting the transfusion indicating to the lab that this is a sickle patient or a thalassemia patient, so that the extended phenotype match can be actually then given. And hematology team, so one of the deaths that actually was there was because the hematology team was not even aware, and there was a delay in the treating surgeon recognized the need for blood. And that initiated the all-parliamentary group No One's Listening report and recommendations to improve awareness across all healthcare professionals, not just hematologists, who will be managing the sickle cell patients. And again, there is a lot of drive to actually improve that education, awareness, and improve the systems. So, it is that importance of keeping everybody connected, knowing and taking the decisions from the angle of safety, and being aware of the special requirements for these patients. Now, pediatric hemovigilance, I won't go too much in detail because we have Helen who would be actually covering this in detail. I'm really looking forward to that talk, Helen. And the pediatric cases account for nearly 7.7%. And that excludes the near miss as well as the right blood, right patient reports. We had 2 deaths, unfortunately, in the pediatric deaths. One was related to transfusion-associated necrotizing enterocolitis, and the other one was due to a delay. Again, you can find all the details of these cases in the report. And one of the main recommendations is actually that protocols must be in place for management of pediatric major hemorrhage, and staff who are dealing with the children should also be familiar with the content of this protocol. The other thing was actually about the risk of hyperkalemia with transfusions in children. So hyperkalemia is a recognized complication with large volume transfusions, and therefore fresh red cells are actually recommended. And the other, in one of the cases, the formula, they were using the wrong unit as well, and therefore miscalculated the volume. So therefore, a system error, which has actually resulted in this, and again, make sure that you're actually then using, and where everything is driven by calculation, we need to be sure that we're using the right formula and the right unit for the pediatric patients. And all the staff should be aware of the specific transfusion requirements and the precautions that need to be taken, and even monitoring it, the recognition and monitoring and management of the transfusion reactions in these young kids as well as neonates is pretty challenging. So, the emphasis again on education and awareness of the administration, the special requirements, and how do we monitor and manage the transfusion reactions. We also collect on the transplant cases. So this is about both hematopoietic stem cell transplants as well as solid organ transplants. By far, the big categories that we have is incorrect blood component transfused. So it is either the wrong components or the specific requirements not met or near misses. And these categories remain the same throughout the year. And again, coming back to the things, you can see the recurring themes. It's about timely communication, keeping everybody informed, and all staff being familiar with the transfusion requirements, especially in a transfusion, in a stem cell transplant. You're having the chimerism, you're having the changes in the blood group as well, being aware of that, and being able to access those transplant protocols, and ensuring your LIMS is also updated is really important. And again, back to that effective communication, which underpins all our effective teamwork as well. Now, cell salvage as well, we do collect the reports, and this again emphasizes the importance of both the reactions as well as error reports relating to cell salvage, the need for traceability, the need for staff education, and the need for that good communication. We have also had where the cell salvage, the autologous blood, was being about to be transfused to another patient as well, and it was the patient asking as to, is this the right blood for me? So the last 5 minutes, I would just like to actually focus. So this was, again, just as I said, a whirlwind tour of all the highlights from the report. But as we stand in this juncture, I wanted to actually just pause and actually say, where have we come from when SHOT was actually started back in 1996? And you can see that. So initially, it was only 20% of the NHS trusts who were actually then reporting, and now we have 100% reporting. And the number of donations has actually gone up, although that is not an impact of hemovigilance, but it is actually providing that assurance. And while, yes, we had a higher number of the TTIs, as we see, there was no transfusion-transmitted infection in 2021. And reporting initially started off as being voluntary, but now what we call as professionally mandated reporting. But we have seen how that good reporting culture, even through the pandemic, actually was staying there. And you can see the vast increase in the number of the reports that are actually submitted, from 169 to more than 4,000 reports that are submitted to SHOT. And we've also then evolved from being a paper-based system to a digital system, and how we have actually then combined and collaborated with all the key stakeholders and having a single point of use. But also what we wanted to do is, what has been the recommendations in the last 25 years? And very simplistically, every year we're making similar recommendations. So where are we now? And what can we actually learn from the themes that are actually coming through in the last 25 years? And what we drill down to is actually, the simple rules of the safe transfusions. Now, let me bring everything together rather than actually going through one by one, so that you have time to actually then look through all of them. Now, we tried to fit it into something as a mnemonic, so that's why it is both with adjectives. But what you can actually look at is that safety culture. Now, although you heard about the safety culture, what we are proposing is more about that openness, the transparency, the no blame culture, and that just learning culture is what we are actually then saying is really needed. And making those appropriate and timely decisions. So as we have seen even in our report now as well, is actually, are we having access to all that information, weighing that risk as well as the benefit, and making that decision. And to make that decision, are we equipping our staff with the right knowledge and the training and access to resources as well as algorithms as well. But also the importance on focusing on people. So although we may talk of a supply chain when it comes to transfusion, we need to remember that it is actually coming from a finite resource. They are voluntary blood donors at one end, processed through blood establishments with people in it, and then we are actually transfusing to the transfusion recipients. So it is humans at the whole end. And we are there to actually also ensure that the right component is going to the right patient at the right time. So it is focusing on the people, providing them with that adequate equipment is really, really important. And not just having the people there, but also they need to be able to communicate and work together as teams. They need to be able to learn as teams, work together as teams, and then they can actually enhance the safety. We've already spoken about the training and competency assessment, and we have repeatedly highlighted that it is not just the technical training skills, it is that non-technical training skills as well. So, it is about that awareness, the self-awareness, prioritization, communication, and having that leadership as well. So you need to be having somebody who can actually then assess all the risks as well. And yes, to the safe systems, it is actually adequately resourced. So even if we're dealing with staffing shortages, but if you have full staff but no appropriate equipment, whether you don't have a functional IT, constant failing computers, or lack of interoperability, again, that is actually a threat to safety. So essentially, we need all of these to be actually then present together for ensuring safer transfusion. And when we look back at all the recommendations, this is actually a crude thematic analysis that we had actually done together as a team. All the recommendations over the years fit into one or more of these. And when we talk about transfusion safety, we have heard from yesterday, and to, moving on to today as well, there are two things that we are actually looking at. One is the safety of the blood component itself. We have spoken about how, the plasticizer example, for example, yesterday, or improving the, the risk from the donations and reducing the risk of infections, and also reducing the pathological reactions. So that is all the making the components as safe as possible. But what we are also seeing, and what the SHOT report has actually shown us, is more than 80% of the reports that we are actually seeing are related to errors. So there is that process-based safety that we really need to actually improve as well to actually enhance safety. So therefore, transfusion safety is actually both of those, and we need to actually then work towards both of them. Now, I would like to actually then just challenge, just pause for a few seconds to actually say, what do we mean by safety and how do we define safety? Now, often, all the definitions that we actually get is the opposite of risk, where risk is low, where there are no incidents. Okay, so safety, we are trying to define by the absence of something else. And, in the safety field, the safety specialists have actually gone through the whole gamut of actually finding out how can we actually define, and through that you can actually see from top to bottom, in the top where you're actually then talking about more zero harm, okay, and freedom from harm or danger. Right down to the bottom is more about what actually makes a safe system is actually having that capacity, the capability, in the system that is actually ensuring that the things happen correctly with the good outcome. So it is that adaptable system. So Professor Eric Holnagel, who we have heard in the SHOT Symposium, as well as Professor Sidney Decker, another safety scientist, a professor in Australia, he spoke at our conference last year as well. So these are the definitions that we are actually going through. And that is where, we have seen this repeatedly, the focus on the safety 2. Now, whatever term that we use, what we are trying to say, whether you're saying safety 1, safety 2, and a new term has come through, safety 3, but what we are really trying to say is make every experience count. So you're not just actually learning from when things go wrong, but when even every day you may have workarounds, you may have, what you're having is that brief and the debrief that is actually going through to actually then help you learn from the event, what went right, what can go better, what can we do better, and what do we need to actually do to actually get that happen. So it is focusing on those opportunities and building that culture. And, like in, this is Bob Weers, who is another safety specialist in America, and who then said, when you're looking at sharks and trying to learn about sharks, if you're only learning about the shark attacks, you're really not getting the full picture about a shark. Now, that may not be the true analogy, but you can get the message. But what we are really trying is actually getting that holistic view, having that finger on the pulse to understand what are the challenges and get a holistic view of the safety. That means it is not just the component safety, but also the process safety, and therefore what do we need to do on that. So just a quick thing, if I put this slide up, I bet every one of you would have actually gone for all the mistakes in that sentence, isn't it? So that is just the negativity bias that we would all be actually having, that, okay, anything that comes up, immediately you want to spot what is wrong and let's go fix it. Okay, but we also need to, yes, that is important, but also we need to actually, it is building that appreciation of also what goes right, what have we done right as well. So, this is just an illustration. When we talk about transfusions, although most of this are that I've actually spoken about when things have gone wrong, you see that the transfusions are largely safe. And you can see these risks, and I'm not going to read out the numbers, but the big red circle is the number of transfusions, more than 2.1 million transfusions. As I said, we get 4,000 reports per year. So you can see that vast number, the transfusions go right. And it's not that ideal conditions have been present every day, and the contexts have not been ideal every day. It is understanding, in that moment, what was the workaround? Is the SOP fit for purpose? Do we need to, do anything about the system that actually then worked then and did not work the other day? So, we are on this journey, as I said, to actually start on combining the safety 1 as well as the safety 2. And we started actually learning from excellence, which is actually part of that safety 2 process. But we are only receiving a trickling of the reports, and those reports are actually all included in the annual SHOT report as well. But what we are really trying to do is, go along that journey of getting that holistic view of the safety. What we need to do better is be able to actually then report that, and also how do we ensure that we can learn from that as well. And therefore, like one of the safety notices that we actually issued last year was where about there was a power shutdown, even the backup generator did not work. That was for a 2.5-hour period, and their staff needed to actually issue blood components. What did they do then? And actually, what does that prompt us to do in our system? That could happen to anybody. It could be a rare event. Although that is a rare event, it just tells you that how did the staff manage in that situation? How did they have that resilience to actually do that? What can I learn from that experience to actually then build a better system at our end? And we have Charlotte Silver, who is actually our patient representative, who also actually is on the ACE group. And this is her words about what is the importance of having that good safety culture, having a culture that you're actually appreciating and learning from every experience. That really matters. So just the last 2 slides, and we have this from a previous report. So ultimately, when we talk about ensuring the right component goes to the right patient at the right time, now this was the system level that you needed all of these in place to be able to actually ensure transfusions are actually safe and the right transfusion goes to the right patient. And from a hemovigilance point of view, we are here, and safety is at the heart of everything that we do. And it is not just getting the data. What are we doing with that data? Are we making a difference? Are we actually bringing about some improvement in the systems? And that is where, we every year we have that distilling the intelligence from the data that is actually coming, and what are the recommendations that we can do. And these recommendations, and also trying to understand what are the barriers and what we can actually do to engage with stakeholders to do that. So this year, these are our recommendations. And the first one is actually about partnering with patients to enhance safety. Now, the why is very clear. They are living libraries of experience. Their lived experience helps us to understand the system from a different perspective and using it to enhance safety. Equally, it is important to remember 2 things. One, by having this, it does not reduce or diminish the responsibility of the healthcare professional to ensure safety. And you can't push the patients. Different patients may be actually then empowered or feel willing to contribute to different ways. So, and when we talk about partnering with patients, it is not just in their own care, it's also with aspects of organizational safety. So like you have your patients co-creating the systems along with the patients as well. So that is one of our main recommendations, and all of this is actually in more detail. And the next, again, as I said, rounding everything up together, the second main is about investing in safety. We have heard from Professor Cheng Hock as well this morning about all the staffing shortages that we have. Different surveys, our UKTLC survey, and all the surveys have actually shown us, even the SHOT surveys, the gaps in our IT as well, and poor resources. So we need to be able to invest in safety to ensure patient safety. And having that leadership to ensure that there is actually a just and a safe learning culture. So while all these recommendations are actually geared towards more a process-based safety, that is the main thing that we are seeing in UK, more than 80% of the reports. So we are trying to actually then ensure that we have a well-resourced system where staff are actually then working together to actually then help improve and enhance safety, and we are collaborating and involving patients. And we have this infographic that we have actually then done, and Professor Mike Murphy's had also written an article a few years ago about that. And this is in line with the 10 steps pathway. What are the different steps and what are the different ways in which we can actually involve patients? So that is again there in the report. You may not be able to read fully about that. But I would like to end by saying that, yes, as a pause point, we need to be able to celebrate a lot that we have actually achieved, and that engagement in that hemovigilance and what we have achieved with the reduction in the errors, although it's a marginal one, but we have the reduction in the ABO incompatible transfusions, reduction in the TTIs as well. But there is more work to be done. And that more work is actually addressing the systems and building more resilient systems and safer systems. And although I stand here, very humbly in front of you, it is actually all the work that has been done, before me, before us as well, throughout, since the inception of SHOT, and currently with not just the SHOT team, but also the working expert group. Above all you reporters as well, who would be actually submitting that. Without that data, we would not be able to actually do anything. All our key collaborators, everybody in the transfusion community, and Jenny Leonard there, who is actually then does all our graphics, so shout out to you, and also to ARC, who actually then, create their magic in our report as well to make it more visual, and it is, I hope it is actually, a good read, and also helping you influence the systems and energizing you to be an agent of change. Thank you.
Thank you very much, Shruthi. We are running a little bit behind, but before you go, just time for a couple of questions. One from Peter Baker, but several other people have
upvoted
it, which is, do the human factors toolkit responses give any indication that laboratory errors may fundamentally occur due to the standard and quality of training within the laboratory? And should laboratories therefore consider reviewing their training programs and competency assessments?
Yeah, I can't specifically answer for laboratory as such. I know as more as an overarching theme, but maybe Alison may be able to elaborate. But in general, yes, it is one part. The problem is complex and complicated, and there are many factors, and training in general, we know, is suboptimal when you're actually having a hurried, abbreviated training, and we often train to documents as more what needs to be done and how it needs to be done. For example, even if we take a simple example of somebody needing an irradiated component, whether it is a clinician or in the laboratory, if they don't understand what is actually the likely implication, that if that is actually missed, you're then having a patient who can actually result in a transfusion-associated graft versus host disease. It is not a conscious decision. It's somebody, we're creating automatons. We need people to actually apply their thinking, have that critical thinking. So training is definitely a component. And also what we notice is even with incident investigation as well, one of the things through our human factors workshop is, it is important that people who investigate incidents be equipped with the tools, how and when to apply those tools, and what are the questions to actually ask, and to identify the effective kappa. So training is definitely an issue, but I don't specifically know with respect to the laboratory staff.
And just one quick last question, an anonymous one. What's a good example of an ACE report that you've received?
This was, there was a bleeding patient outside the hospital, and I can't go through all the specifics, I can't remember all the specifics, but this was a case where the policeman had come in to collect the blood components to ensure timely administration of the component to a bleeding, dying patient. Now, strictly they didn't have an SOP for somebody who is not a hospital staff to be actually taking that, but they made that risk assessment and they actually then gave that, and they also modified to actually then include non-hospital staff to be able to actually help out. So that is an example there, but equally there are several examples. Now what we're also saying is, learning from excellence, although started off, and even Professor Adrian Plunkett, who started this, actually said, although it was, you're not just looking for over and above, also a good innovative example as well. What have you done in a difficult circumstance? How have you improved that resilience? What have you done without increasing the risk and without compromising the safety or ensuring that timeliness? That is all valuable. How have you worked together? How have you improved communication within your team? We would welcome all of these reports. And we are learning how to learn from these reports as well. So we are also on a journey. So we would welcome all of these reports, and then we would be seeing more in the next year's report.
Thank you.
Thank you. Thank you.